So, hello everyone. Welcome to the IPNA webinar. I'm Pankaj Hari, Professor of Pediatric Nephrology at the All India Institute of Medical Sciences, Delhi, India. And I will be the moderator for today's webinar. Just to remind you, as before, the recording of this webinar will be available at the IPNA website for some time. And just to remind you that you can post your questions in the question box during and even at the end of the webinar. So today's webinar is on steroid-resistant nephrotic syndrome. It's an update from the IPNA guidelines part 2, therapeutics. And the presenter for this webinar is a very, very accomplished researcher and a key member of the guideline core group on clinical practice guideline on steroid-resistant nephrotic syndrome, Dr. Agnes Trotman. She has been involved in the literature search, synthesis of evidence, and drafting of evidence table for these guidelines. And as you would know that these are very important and key steps in the formulation of a reliable evidence-based clinical practice guidelines. Agnes Trotman is a pediatric nephrologist at the Center of Pediatrics and Adolescent Medicine of the University of Heidelberg in Germany. She graduated at Heidelberg Medical School in 2008. She completed a specialization in pediatric nephrology, working as a clinical fellow in Heidelberg and at Great Ormond Street Hospital in London. And currently, she's also completing an additional specialization in pediatric endocrinology and diabetology. Her research interests include congenital anomalies of the urogenital tract, renovascular hypertension. However, she focuses mainly on nephrotic syndrome. Agnes is a coordinator for the Clinical PODONET Registry for the primary steroid-resistant nephrotic syndrome in children since 2009. And this is a project that aims to characterize steroid-resistant nephrotic syndrome, the clinical findings, genetics. It aims to evaluate the immunosuppressive treatment strategies and is aimed at providing insight into the long-term outcome of this progressive renal disease. So now I invite Dr. Agnes Trotman to begin the seminar. Over to you, Agnes.
Thank you very much for this kind introduction and welcome to part 2 of the update on the IPNA clinical practice recommendation on steroid-resistant nephrotic syndrome today. We are focusing today on the therapeutic management in the guideline. It's my great pleasure and I feel honored to present the recommendation on behalf of the guideline group. What are the challenges in steroid-resistant nephrotic syndrome? It's a rare disease. It's only 15% of all idiopathic nephrotic syndrome in childhood, and it can be also a severe disease. Many patients progress to end-stage renal disease. The etiology is very heterogeneously, and the disease courses are highly variable. Multiple, slightly different treatment strategies has been used to treat SRNS so far, and altogether there is a lack of high-quality evidence. To start with the etiology of SRNS, up to 30% of SRNS have a genetic cause, and this leads to structural anomalies of the glomerular filtration barrier due to mutation in podocyte-associated genes. The rest of SRNS patients have an immune-mediated disease. Usually they respond to immunosuppressive treatment. However, the pathophysiology of the immune-mediated disease is still not really clear. It's still like a black box. It's thought to be a mixed T and B cell order leading to production of a permeability factor. Identifying a genetic cause has impact on renal prognosis. Several studies have shown that patients who have a genetic cause of disease have a much more unfavorable renal prognosis than patients with non-genetic disease and responding to treatment. Depending on the response to treatment, we can also classify nephrotic syndrome into steroid-sensitive and steroid-resistant nephrotic syndrome, also to CNI responsive and CNI resistant steroid nephrotic syndrome. We can also identify multi-drug resistant nephrotic syndrome, and all the forms of nephrotic syndrome have a differential risk to progress to end-stage kidney disease. And that I will show in the next slide, not only genetics, but also the treatment response matters in renal prognosis. In a study with a follow-up of 2 years and a study, the long-term follow-up up to 15 years, it has been shown that patients who achieve complete remission initially have a very favorable renal outcome. So for example, the risk to progress to end-stage renal disease at 10 years, it's only 5% in patients who achieve complete remission, whereas the ESRD risk is up to 60% in patients who did not achieve remission at all. The prognosis for patients with partial remission is slightly better than for the patient achieving no remission. So if the treatment response matters, the question is, how can we achieve remission? This slide summarizes multiple slightly different treatment strategies and combination of drugs applied in steroid-resistant nephrotic syndrome so far. However, what is the best drug and which drug should be used first based on the evidence? If we enter steroid-resistant nephrotic syndrome to PubMed, then we got back a lot of entries. But if you look more in detail, then there are only 26 studies in a total of 1,077 children performed since 1970. There are more observational studies on the conservative SRNS management in approximately 3,500 children. So we appreciated when IPNA came up with the initiative to establish a clinical practice recommendation for SRNS. To give you a short overview on RCTs in SRNS since 1970, I would like to point out that there are 10 studies comparing CNI with other drugs and 3 comparing with placebo and control in a quite small study population. There are more observational studies for immunosuppressive treatment, and there are also more registry and outcome studies coming up, evaluating several standard treatment strategies from different parts of the world. And at this point, we would like also to encourage you to enroll your SRNS patients to the existing registries. What are the aims of preparing the clinical practice recommendation? To provide state-of-the-art guidance, to be mindful of different resources and situations, to be a starting point of a work in progress, to provide common ground for collaborations and further studies, and to suggest future lines of research. Dieter Hafner was the lead of the core group, and he collected 18 pediatric nephrologists from all over the world and invited also an adult nephrologist and Jan-Ulrich Becker as a nephropathologist and also an external expert group. The methodology we used, we used the GRADE method. We identified 9 PICO questions and followed the right statement for practice guidelines. For those who are not really familiar with these practices, there's a very nice SOP guideline for establishing a guideline, and it can be downloaded from the IPNA website. So our core group developed recommendations based on the evidence from the literature. And I would like to mention that at many steps, it was only possible to make suggestions for sRNS, as the evidence was quite low in a few fields. The strength of recommendation and the evidence quality were then graded by using the grading system from the American Academy of Pediatrics. I will show the system in the next minute. After the recommendation were developed, the recommendation were sent to a voting panel, including 23 pediatric nephrologists of each regional IPNA society, and they provided us with a level of agreement using the Delphi method. And luckily, most of the recommendations were directly accepted, and there were only a very few recommendations who needed to be discussed again, and the wording needed to be modified by our core group. This is the mentioned AAP grading system. I think most of you are familiar with the grading system. Based on the evidence quality, we can differentiate between level A, B, C, D, and X. And we can also strengthen the recommendation using a strong, a moderate, and weak recommendations. As the evidence in sRNS is not such as high, we mainly needed to use the level B, C, and D, but also in several situations level X. Yes, so in pre-COVID-19 times, we had the opportunity to meet in person in Leuven in Belgium in December 2018. And as you can see here, we had a long, constructive and fruitful discussion, and we worked very hard on an algorithm for the sRNS management, as you can see here from our whiteboard notes. Finally, this is the product of our work and discussions, and we hope it will be helpful as a first starting point for the further work in progress. In the next minutes, I would like to guide you step by step through the algorithm. The diagnosis, initial workup, and management was covered by the excellent webinar from Marina Vivarelli last week. It was part 1 of presenting the guidelines. And I would like to start directly now with the confirmation period. So the confirmation period is this period between week 4 and 6 after start of oral prednisolone. Why do we suggest to introduce a new term and a time period? So most pediatric nephrologists consider a child steroid resistant after 4 or 6 weeks. However, there's no really universal consensus on the minimum duration of daily steroid exposure. We know that almost 95% of children achieve remission within the first 4 weeks. And given the fact that a small percentage of children will also achieve remission within 2 additional weeks of daily prednisolone, or by using 3 pulses of methylprednisolone, we decided on an additional time window of 2 weeks called the confirmation period. And during the confirmation period, we also recommend to perform the genetic testing and a renal biopsy and to initiate RAS inhibitors. So as first line non-immunosuppressive treatment, we recommend starting RAS inhibition once the diagnosis of sRNS is made. Why do we recommend to start RAS at this point, 4 weeks after starting the oral prednisolone treatment? We know from larger studies in CKD patients and from small studies in sRNS patients that RAS blockade is able to reduce proteinuria dose-dependently by 30 to 50%. Therefore, we recommend to quantify the change in plasmonic proteinuria after starting RAS inhibition before starting immunosuppression. Another aspect of starting RAS early, so also before start of immunosuppression, is to differentiate the antiproteinuric effect of RAS inhibition from the later effect of immunosuppressive drugs. And we hope that this differentiation will help for further studies to find a basis, and you do not have always the question, what is the confounding role of RAS inhibition? When using RAS inhibition, we suggest to aim for the maximum tolerated dose and to use RAS inhibition with non-renal metabolism. Of course, we need to be cautious in patients who tend to have hyperkalemia or who have an impaired renal function in the beginning, or who shows sign of intravascular volume depletion. And we also make sure that we counsel the patient and the family that contraception is necessary in fertile females and that the medication should be stopped if there's recurrent vomiting or diarrhea. I also would like to point out that it's very important to differentiate between genetic and non-genetic SRNS early in the diagnostic phase. So to recap from last time, we recommend, if genetic testing is available, that genetic testing be performed in all children with primary SRNS, except in patients with secondary cause or with initial steroid sensitivity. And if the child is having suspicious forms for genetic disease, for example, if this is a familial form or the children is having extrarenal features, then we suggest to give it priority and to perform genetic testing before a kidney biopsy, provided the results will be readily available within a few weeks. We will come back to genetic SRNS, but I would like to start first with guiding you through the algorithm for non-genetic SRNS. Based on the 10 RCTs I've shown you and based on larger observational studies in SRNS, we recommend to start cyclosporin or tacrolimus as a first-line immunosuppressive treatment in SRNS. We suggest a minimum period of 6 months to determine the response to CNI. Why we decided to use a period of 6 months. So in the literature, it's not really clear which time period should be used to evaluate the CNI response. In the RCTs, several different time windows has been used, so between 2 and 12 months, but most of the studies used 6 and 12 months. And given the fact that a substantial proportion of patients will respond to CNIs in weeks up to months, we decided to determine the response at 6 months. We recommend to withhold treatment with CNI or delay treatment with CNI if the eGFR is below 30, if there are signs for acute kidney injury, or if there's uncontrolled hypertension. When we're discussing treatment with calcineurin inhibition, we thought in our group it would be helpful to suggest or to give some guidance for the starting dose, and we are giving this suggestion based on the studies, on the RCTs and observational studies. And we also recommend to measure trough levels by tandem mass spectrometry, and that are the suggestions for the trough levels initially for calcineurin inhibitors. We think it's very important to monitor the trough levels, and for example, we suggest to measure them initially weekly until the steady state is achieved, for example, during the first 4 weeks, and then measure it every 1 to 3 months, plus the serum creatinine as a safety parameter. We recommend also making parents and patients aware of possible side effects, especially for hypertension, nephrotoxicity, for the cosmetic effects in cyclosporin, and the risk for glucose intolerance in patients treated with tacrolimus. However, if we are using the drug monitoring, then we will be able to try to prevent mostly the side effects by using a minimal dosing of calcineurin inhibition. We discussed also quite a lot about the role of steroids as co-intervention to calcineurin inhibitors. Looking for the studies and after our discussion, we think that we do not recommend a prolonged routine treatment with prednisolone in conjunction with CNI and RAS inhibitors. And we suggest tapering prednisolone and discontinuing after 6 months. We also provide you with a suggestion for a tapering scheme after CNI initiation. As you can see, this is a D-week recommendation, so there are not really data available to guide on this. Of course, if a child is having severe signs for steroid toxicity, then wean off the steroids more quickly. So now we're going back to the CNI and to evaluate the response at 6 months. If the patients achieve complete remission at 6 months, then we recommend to reduce CNI to the lowest doses required to maintain remission and to continue with CNIs for 12 to 24 months. We appreciate that there are different options and strategies and opinions on how long to continue CNIs in a patient who have achieved complete remission. So there's a window to decide what to do. But we have also always in mind that when a patient has achieved complete remission, our aim is maintain remission and avoid nephrotoxicity and relevant side effects. And I think when we are having this in mind, then we will decide in our patients how long we continue the CNIs. We discussed also a lot about the role of MMF in SRNS. And we felt that MMF does not have a role to induce remission in SRNS, but it may have a role in maintaining remission. Some or small observational studies have shown that it's possible to convert CNI treatment to MMF, either completely or as a combination MMF plus CNI in a reduced dose, and still the patient remains in remission. However, there is also a recent RCT showing that tacrolimus is superior MMF in maintaining remission. So at that point, we can decide to consider a conversion to MMF. And if we are starting MMF, we suggest a starting dose of 1000 milligram per square meter per day, divided into 2 doses, and using also therapeutic drug monitoring with MPA under the curve. And these data are based on the experience in steroid-sensitive nephrotic syndrome and frequent relapsing nephrotic syndrome. If a patient on CNI treatment develops a relapse, we recommend to check first the adherence to CNI and ensure that there are adequate trough levels and to add a steroid challenge. So giving oral prednisolone 60 milligram per square meter daily until remission is achieved or for a maximum period of 4 weeks. And when remission is achieved, then of course taper prednisolone. And if the patient achieves complete remission, we can call it a steroid-sensitive relapse. And here again, you can consider the use of MMF to maintain remission and to reduce the dose of CNI. If a patient develops a relapse after withdrawal of CNI, you can challenge him also with steroids, but it's also reasonably to restart CNI or the immunosuppressive treatment who was able to prevent relapses before and monitor the trough levels. In both cases, if there's no response within 4 weeks, if there are frequent relapses, or if there are side effects of medications, then we recommend to follow the refractory SRNS protocol, which I will show in a minute. We discussed also quite a lot about the partial remission. Partial remission defined as a reduction of proteinuria to more than 20 but less than 200 milligram per millimole and a serum albumin above 30 gram per liter. So if the patients achieve only partial remission at 6 months, we suggest to continue calcineurin inhibitors at the initial dose for further 6 months. If after 12 months there's a complete remission, everything is fine, and you will follow the way with minimization of CNI dosage, what I've just shown. If the patient is having no remission, then it's a CNI-resistant, steroid-resistant nephrotic syndrome. And the difficulty is still when the patient is still in partial remission. We appreciate also here that there are different ways to go and different approaches. And here it's nothing really to advise. So it will be an individual decision in your team and with your patient. We can say that CNA may be stopped or continued. If there's still an absence of at least partial remission at 6 months, then we define it as a CNI-resistant steroid-resistant nephrotic syndrome. And in that case, we recommend to discontinue the ineffective CNI treatment. We just discussed further a lot about if we should recommend rituximab as a first-line, second-line approach. However, when we were looking through the literature, then we thought the data are not convincing enough to recommend as a first-line, second-line approach. There are small observational studies in those patients who were treated being multi-drug resistant, and rituximab was used as a rescue therapy. And in those patients, approximately 30% of patients achieved remission. But there's also an RCT in multi-drug resistant nephrotic syndrome comparing rituximab with standard treatment, and that RCT did not show advantage of rituximab. So also to stimulate all of you probably or potentially to establish new clinical trials, we suggest to enroll a CNI-resistant patient in an available clinical trial. If the clinical trial is not available, we suggest to consider rituximab. And if there's still an absence of complete remission after 12 months of CNI or of treatment with 2 mechanistically different steroid-sparing agents, then we define it as a multi-drug resistant nephrotic syndrome. And for that case, there are not many studies. There are only small studies. And in that case, you may consider to use ofatumumab or extracorporeal treatments. When you're using rituximab, we recommend to evaluate first for potential contraindications. So we recommend a screening in case of clinical suspicion or endemic background for tuberculosis, hepatitis B, and JC virus. Usually 1 to 2 rituximab infusions given within 2 weeks are sufficient to reduce the CD19 cell count below 5 per microliter. And given the high mortality of pneumocystis jirovecii pneumonia, we suggest to administer as an antibiotic prophylaxis cotrimoxazole for a period of 3 up to 6 months, depending on the B-cell recovery and the immunosuppressive co-medication. About 30% of patients develop after rituximab hypogammaglobulinemia. We recommend to not substitute it routinely. However, consider to give immunoglobulins in cases of low serum IgG in combination with recurrent or and a severe infection. Now we are coming back to the genetic steroid-resistant nephrotic syndrome. And first of all, I would like to point out again the importance of identifying a monogenic cause.
So then we will be able to provide specific treatment when specific treatment is available. For example, the coenzyme Q10 treatment in a patient with a defect in the CoQ pathways. And we can decide about further treatment. We have the possibility to withdraw ineffective and harmful therapy. For example, in SMORCL1 patients who are having an immunodeficiency, might be immunosuppression treatment harmful because they are more at risk for infections. And to provide an estimate of the risk of ESKD and risk of post-transplant recurrence. And it will also allow us the screening of dangerous comorbidities, for example, Wilms tumor and gonadoblastoma in WT1 mutations. And it will also provide us family counseling. We're going back now to the confirmation period. So between week 4 and 6 after starting oral prednisolone treatment. Ideally, we will have the genetic results back within 2 weeks, and then we will receive the screening for all known podocytopathy genes. So at present, we are recommending to perform next generation sequencing panels with all known podocytopathies, and in our table in the guidelines we have listed already 79 known podocytopathy genes. And the genetic results will then enable the decision on further immunosuppression. And given the likelihood of non-responsiveness of patients with structural defects in the glomerular filtration barrier, we recommend at present to withhold CNI and to stop prednisolone treatment in those patients and to continue RAS inhibition and other supportive treatment. If the genetic results are not available at the end of the confirmation period, of course, we recommend to start treatment with CNI and to reassess after receiving genetic results. The most difficult discussion was when to withdraw immunosuppression. So the monogenic SRNS patients are unlikely to benefit from prolonged and potential harmful immunosuppression. So therefore, we recommend to discontinue ineffective treatment. And this is the same for multi-drug resistant steroid-nephrotic patients. And we recommend to continue with non-immunosuppressive management, and the decision to continue or discontinue the immunosuppression should follow parental counseling regarding the benefits and the harms or risk of the medication. Another very difficult point, and definitely not really to answer at present, is what to do with those patients who were treated with immunosuppression and achieved a partial or a complete remission. So there are very few case reports in the literature on those patients, and mainly these are WT1 patients. All the patients were treated with calcineurin inhibition, and we know that the patient that CNIs can stabilize the podocyte cytoskeleton. However, all the patients were also treated with RAS inhibition, and so it's not really clear to differentiate the effect of immunosuppression or RAS inhibition in those patients. So we recommend strongly in those patients to review first the pathogenicity of the genetic variants according to the guidelines of the American College of Medical Genetics. And if it's a confirmed pathogenic genetic variant, then we suggest to assess the benefits and the risk of immunosuppression continuing or discontinuing in your team and with the parents. At the end, I will present a few recommendations for post-transplant recurrence. And I would like to remind you that there's a differential risk for post-transplant recurrence. As I mentioned, genetic patients have a low response rate to immunosuppression and therefore a low or zero recurrence risk. Patients with immune-mediated disease and a circulating vector disease usually respond well to immunosuppression, but also have a high recurrence risk due to suspected circulating vector disease in the allograft. So at this point, I repeat it again, and we have repeated also in our guideline, if possible, we recommend a genetic screening to inform about the recurrence risk post-transplant. How to manage a child who achieved already end-stage kidney disease and how to prepare for first transplantation. So first of all, we recommend kidney transplant be offered to children regardless of genetic or non-genetic cause of SONS. And we recommend that the anticipated recurrence risk should be discussed with the family in planning the renal replacement therapy. And another issue we discussed in order to avoid complications, especially thrombotic complications during transplant. So if the transplant will occur before complete resolution of the nephrotic syndrome, we suggest considering medical or surgical nephrectomies prior to transplantation. How to monitor for post-transplant recurrence. So if there's a child with a residual native kidney function, then it is important to measure the urine protein and creatinine ratio to assess the prevalent proteinuria before transplant and at latest at day of transplantation. Then we suggest to monitor for post-transplant recurrence with daily monitoring of the urine protein and creatinine ratio throughout the initial transplant period. And we suggest to diagnose early transplant recurrence to a recurrence within the first 48 hours post-transplant when an previously anuric child is diagnosed with a proteinuria above 100 milligram per millimole, and a patient with a prevalent proteinuria with an increase of more than 100 milligram per millimole in the ratio. Other suspicious first signs for post-transplant recurrence is the early onset acute tubular necrosis or an initial graft dysfunction. The further monitoring depends on the recurrence treatment and the response to the recurrence targeted therapy. If there is hopefully no transplant recurrence, we suggest a further monitoring, for example, weekly for 4 weeks, monthly for 1 year, and thereafter every 3 months. Is there an allograft biopsy necessary to diagnose transplant recurrence? We discussed about that, but in the end we felt that the biopsy is not required to diagnose the rapid recurrence of nephrotic syndrome, but of course is recommended to exclude differential diagnoses in the setting especially of subnephrotic proteinuria and delayed graft function and delayed recurrence, especially if it's later than 3 months post-transplant. And then not only histopathology should be assessed, also electron microscopy should be included, infection should be excluded, and donor-specific antibodies should be screened. Is there any preventative strategies to avoid post-transplant recurrence? Unfortunately, there is not sufficient evidence to recommend intervention strategies to prevent the recurrence in children undergoing a first kidney transplant. However, if a child suffered from recurrence in the first allograft, then the risk is very high for another recurrence in the second graft. So it's 60 to 80% the risk. And there are a few case series available, and they suggest to use prophylactic plasmapheresis or immunoadsorption or lipid apheresis and perioperative rituximab to avoid another recurrence in the second graft. If a post-transplant recurrence has been diagnosed, we recommend implementing the recurrence-specific therapy as soon as possible. Again, unfortunately, there are only very few small studies showing that usually multimodal treatment strategies has been used to treat recurrence after transplant, so including increasing doses of CNI, intravenous methylprednisolone pulses, plasmapheresis or immunoadsorption, and rituximab. And it's reported that the response to the recurrence-specific therapy is approximately 50 to 60%, and then the graft survival at 10 years will be approximately 50%. Unfortunately, those patients who do not achieve remission after the targeted therapy have a poor prognosis, and if there's no complete remission achieved, we suggest to initiate RAS inhibition as a renoprotective and antiproteinuric treatment. Yeah, we hope that the current clinical practice recommendation will help you in the treatment patients in the SRNS management, and there's still a long way to go. So I think in a few parts of the guidelines we are quite advanced, but in a lot of parts of the guidelines we are here at the beginning of the way, and of course, further adequately powered clinical trials are needed, and we provide you also with recommendations for future research in our supplementary material in the publication, and we hope that we were able to stimulate it to start to perform in new studies, that we can update the clinical practice recommendation with new data in the next few years. I would like to thank you for your attention to the webinar, and I will close the presentation with referring to the previous and the next webinars, so especially to the part 1 of the guidelines, and also then to the webinar on autosomal dominant polycystic kidney disease and on congenital nephrotic syndrome performed by Olivia Boyer. Thank you very much. I'm open for questions now.
Thank you, Agnes, for very nicely summarizing the very extensive guidelines on the therapy of steroid-resistant nephrotic syndrome. There are multiple questions on the chat box, and we'll start taking the questions related to therapy first. So just one question where I'm also interested in, and there is a question in the chat box, and just to tell you, and maybe you're aware that the Indian Society of Pediatric Nephrology very recently came up with the guideline on resistant nephrotic syndrome a few months back. And most of the features or the recommendations of Indian guidelines, they are similar to what is there in the IPNA guidelines, except for some minor, differences. And one such difference is that using mycophenolate at a eGFR of less than 30. So there is a question that if the creatinine, this is a question in the chat box, that if the creatinine is high at 3 months persistently in a patient who has multi-drug resistant nephrotic syndrome, that means he has not responded to CNI, do you consider ofatumumab or consider stopping immunosuppressive drugs?
So yes, understand correct. So if you have a multi-drug resistant nephrotic syndrome already, and the question is to start ofatumumab, is that correct?
No, he's trying to find out if the creatinine has remained high over a period of 3 months, then this patient has already progressed, and so is it justified to continue immunosuppression in this patient? Because he's already into a CKD now.
So if it's a multi-drug resistant patient, and if we have tried already several mechanistically distinct agents, then we would consider to stop the immunosuppression. and to continue with the non-immunosuppressive management. And sometimes, so we have seen in some patients, then after stopping the immunosuppression in those patients, so for example, I remember one patient of mine who has an increased GFR after that. So she was already on a GFR of 30, and then we stopped all immunosuppression, continued only the supportive treatment, and then the renal function was increasing again to around 50, and they stayed at this eGFR for another 5 years. And then, of course, there was the natural drop of the GFR, and then she required renal replacement therapy. But in that child, for example, we have seen that GFR was getting better after stopping the immunosuppression, and the quality of life in this girl was better after stopping the medication.
Yeah, so the final word is, if you are progressing into CKD, then it is better to avoid immunosuppression. Is that right?
Yeah.
Okay. Yeah. There's another question that what is the that 20% of resistant nephrotic syndrome may have minimal change disease on biopsy, and what is the role of IV cyclophosphamide in those patients?
So when looking at the literature, so the CNIs are superior against cyclophosphamide, and so far we do not recommend to administer cyclophosphamide to patients with steroid-resistant nephrotic syndrome because the side effects are too high, and other medications are there to have a better effect. We discussed on that quite a lot in low research settings, because we have learned, unfortunately, CNIs are not affordable or not available in many countries. And in that case, we discussed, and we have also tried to make a suggestion in our guidelines. If no CNIs are affordable or unavailable, you may consider to use cyclophosphamide if this is available, but if you see there's no response to it, then please stop it. But of course, in these settings, it could be considered, but otherwise the risk-benefit assessment is again not good enough for it.
All right, thank you. And there's another question. This is about at what percentage of interstitial fibrosis you would consider avoiding a CNI in a steroid-resistant nephrotic syndrome patient?
Oh, for me that is difficult to answer because to be honest, I cannot answer this question, the percentage of interstitial fibrosis. I think always you have to combine to see what's the renal function, but I don't think that I would base this only on the percentage of interstitial fibrosis. So, but that is a difficult question, and I cannot.
Yeah. So what we do, and I may answer it. If you have interstitial fibrosis, but this is for the CNI has never been tried, it may still be worthwhile trying a calcium inhibitor. But if somebody has a percentage fibrosis of more than 30-35%, or as you said, increasing creatinine or slightly raised creatinine, then it may be a difficult decision to consider CNI in those patients. But otherwise, 15-20%, one can easily go ahead and use CNI in those patients, because that's the only hope. I mean, because that's a drug that is most effective in these patients. There's another question that what is the role of tacrolimus and addition of mycophenolate in those who have partial response to tacrolimus? So adding mycophenolate if there is a partial response after, let's say, 6 months of tacrolimus therapy.
So far that I'm aware, if the patient did not achieve partial remission at 6 months, then our recommendation is first to continue CNI to reassess the response after 12 months. So far, I'm not aware that adding MMF to induce remission will have a benefit. So studies are showing that MMF has may have a role in maintaining remission, but not additionally in inducing remission in SLNS.
No, but the question is that if the tacrolimus is not working, so there is a partial response only to tacrolimus. So would adding mycophenolate help in those patients?
So if it helps, it's fine. But then you still cannot differentiate if this is the effect of tacrolimus or if it's the effect of MMF. Of course, there are always desperate situations in treating patients with SRNS. And yeah, if it's working, then of course it's fine. But you cannot differentiate what is the effect of which drug in the end.
So you're right that one can add mycophenolate or maybe consider using rituximab, but then these are all rescue therapies without much of evidence in the literature. There is a question about the role of chlorambucil in patients who have partial remission or are frequently relapsing while on CNI, whether adding chlorambucil. So what is your take on that?
So as there are no RCTs on chlorambucil, we were not able to comment on that in the guidelines. And we in Germany do not use chlorambucil, so I do not have experience on that. But I think it's the same as in cyclophosphamide as in cytotoxic agents. So.
Yeah, so in fact, chlorambucil was being used in about 30-40 years back, but it's quite neurotoxic, so high risk of seizures. So that's why it's been given up. And if one has to use a cytotoxic drug, then it is cyclophosphamide and not chlorambucil at all. Then there is a question as to if there is no rituximab available, what can be a second-line treatment for resistant nephrotic syndrome?
If no rituximab is available, of course, if you have not tried MMF, you can try MMF as another mechanistically different agent to CNI. If rituximab is not available, I would think ofatumumab is also not available. You can still think of extracorporeal treatment if they're available, or in the end, if all the other treatments has not helped to achieve remission, then of course consider together with the patient and your team to discontinue the immunosuppression and to continue RAS inhibition if the renal function is still fine.
Okay, and there's a question about will you stop RAS inhibition if the serum creatinine is rising in resistant nephrotic syndrome?
Yes, if it's rising and if the eGFR is below 30 and if it's going to develop an end-stage kidney disease, then I would stop RAS inhibition.
Okay, there is a question about using intravenous methylprednisolone during the confirmation phase or confirmation period. Would you recommend using IV methylprednisolone?
So the reports on the methylprednisolone pulses are controversial. So they are given in several centers, interesting more in the developing countries, routinely to the patients. But the data do not show that there's an advantage of about another 2 additional weeks when giving oral prednisolone. And we've learned from the colleague from Nigeria, for example, that there it's too expensive to use methylprednisolone pulses because the children need an IV and need to admit to the DELCA unit. So they are only using oral prednisolone treatment, and the data do not show an advantage 2 weeks oral or 3 IV methylprednisolone pulses.
So there is a question about newer B-cell drugs and which are the drugs that you would consider, obinutuzumab or belimumab or bortezomib. So do you have any experience in the use of these drugs for resistant nephrotic syndrome beyond rituximab? This is what I think they are asking, yeah.
So unfortunately, we couldn't really find data, and I personally do not have experience in those stacks, to be honest. I'm sorry.
Yeah. Yeah, and these are drugs which are used in other as immunosuppressive agents in other conditions. We also we don't have experience using belimumab or obinutuzumab in patients with nephrotic syndrome. There is a question about if the cyclosporin level, cyclosporin is started at 5 milligram per kg per day, and the trough level is less than 80. What would you prefer to do? Increase the dose or start the patient on tacrolimus?
Sorry, in between, I couldn't understand the question. So I understood the question until you spoken about the level. So if you have started.
I'll repeat. Yeah.
Mm-hmm. And if below 80, for example.
Would you increase the dose or start tacrolimus?
First, I will discuss with the patient if he's taking the medication all the time, if he's taking it correctly, and if there are not any other interaction with that. And it depends, and with stage, if the patient has already achieved remission, then you can accept a lower level. But I'm not sure if the question is aiming for to achieve remission or if it's in remission. So if the patient is in remission, then of course.
If no remission, then
is not in remission.
If no remission, despite 5 mg per kg CNI levels of less than 80.
Yes. So you can still try to continue CSA. The data so far cannot prefer one of the calcineurin inhibitors. The data what we look for showing that they are quite equivalent, but it's not that you will prefer a drug based on the data. I think if everything is fine, the patient is taking the drug and the compliance is there, then yeah, you could try to increase the dose and see if then remission can be achieved or not. But of course, you have to look toxicity signs and side effects.
So that's right, and one can increase the dose and to achieve the level, right? There is a question about role of plasma exchange in resistant nephrotic syndrome.
So what we have seen, it has been used only experimental therapy. So some small case heroes have used plasmapheresis as a rescue therapy, but they're not really data to recommend it. So you may consider it if you're desperate and if you do not have any other option. But so far we do not have data to state on that.
Okay, there's a question on what is the role of anti-diabetic agents in the treatment of resistant nephrotic syndrome from Dr. Hesham Safo.
If the patient has developed diabetes?
No, and perhaps he's asking about the flogglutazones and the anti-diabetic agents in the treatment of resistant nephrotic syndrome as therapeutic agents for inducing remission.
For that, I do not have experience. Do you have experience in that?
Yes, no, we haven't used it, and the early trials in the FONT trial, and they did not show much of benefit. So perhaps these are drugs. I mean, still in the experimental phase, they are not useful in achieving remission in nephrotic syndrome. They were failed trials with the use of these drugs. Okay, we can just have one or two more questions, and there's a question about a child who didn't go into remission at 8 weeks, and the person is asking that is CNI indicated. So a child didn't go in remission into first 4 weeks, but subsequently by the end of 8 weeks, the child goes into remission. Is calcineurin inhibitor still indicated, and would you like to do a biopsy here in this patient or not?
Yeah, so if the patient has, usually if the patient has achieved remission within 6 weeks, then it's a late responder, and then it's a steroid-sensitive nephrotic syndrome. So, but if the child was not in remission and at 6 weeks, so that's important to know for the identification of the diagnosis, if it's an SSNS or it's an SRNS, and then then I would you can call it as a steroid-resistant nephrotic syndrome if the child was not in remission at 6 weeks in the end. Then, of course, then start the process with genetic and renal biopsy. And if you have any suspicion for any secondary cause in this patient because of hypertension or hematuria, then of course.
The question is that if the patient goes into remission but goes late, 6 weeks, 8 weeks, he goes into remission, would you still do a biopsy? Would you still give him CNI? He's gone into remission now.
So so in the end, you really have to decide. Usually, the definition says when it goes into remission. If no remission at 6 weeks, then it's a steroid-resistant nephrotic syndrome. That might be any overlapping disease, and I think that needs to be decided individually if you know more about the patient.
So if the patient has gone into remission, then perhaps you may not do, if you've already done a biopsy, it is fine, but you may not require CNI, you could use other drugs. There's a question about the role of high cholesterol levels in inhibiting the response to cyclosporin. What is your comment on that?
So we recommend also in our we state in our guidelines, or we're discussing about the role of high cholesterol levels and as a complication of nephrotic syndrome. And if there are high cholesterol level above 130 milligram per liter, we recommend to use age-dependent lipid-lowering therapy, starting with evaluating by a dietitian and anything.
No, I think Agnes, this question was about whether you would prefer not to use cyclosporin because high cholesterol levels would interfere with the response to cyclosporin.
I don't think so. So
there is no such recommendation, irrespective, because most of these patients will have high cholesterol levels. One doesn't have to bother about the cholesterol level and use CNI. So I'm afraid we are running short of time, and we already have some of the questions unanswered, but there was an very active participation by the attendees, and I think it was they have multiple questions, and I hope that you will be able to take these questions on an individual basis or through emails. And it was wonderful having you for this webinar, Agnes. And thank you everyone for attending this webinar, and thank you, Agnes, so much for this nice presentation. Thank you.
Thank you. Bye-bye.